the CT FFR. So I need some volunteer to tell me this is the LAD. How would you interpret this result? Negative study. Okay, anyone else would like to challenge that? So Dr. Lima brought really a good point, validate the data. So those who use CT-FFR, you can go to the website and actually select your own segments and click, click, click. So this is me just taking a screenshot to show you there's something off with this CT-FFR. So let's look at the left main. CT-FFR is 1, goes down to 0.89, and then goes up again to 0.91, and then 0.91. So there's something off with the CT-FFR. So just keep that in mind. The CT-FFR is a simulation of the flow based on the size of the artery, based on the myocardial mass, based on the lesion that was simulated. So when you see something like this, and I've seen it in the left main, osteal lesion, when the CT-FFR start going up again, there might be some post-stenotic dilatation as we saw, and that really is going to throw off the data. So when I believe the anatomical data is going with severe, and there's something here, I don't stop here. So I called the cardiologist and I said, tell me how symptomatic is this patient? They're like, yeah, symptomatic, family history. I'm like, you need to proceed with heart cath. So this is just like, you know, a story just to point out to you that CT-FFR can be good, but here's the angiogram. And clearly what we saw before, and we asked them actually for IVUS. So they confirmed on the IVUS that the lesion was 3.1. Was amazing correlation, and the proximal segment, like, you know, to the lesion was ostium, so they could not go, and they went distal to it, and they went up to 13, 14 millimeter. So they called it severe, and you can see they intervened on the LAD, and that's the final result. So just to point out to you again, we talked about this in the morning. This lesion was purely non-calcified, as you saw. I mentioned the power of 0 applies for the public level and individual level. However, there's some risk factor you have to really keep in mind. One of them is the FH. I think we are not doing enough of screening with lipoprotein A, ApoB, and I think that's something to keep in mind, that this patient can benefit from one risk factor, like for anti-lipid management and what so. So this is a case, I think, just to point out again, the CT-FFR is not always like, you know, as I would say immune to, like, you know, the measurement errors that can be encountered. Any question about this case before I show another case quickly, if we have time? Go back here. That's a good point. So what to do with these clefts? So the way, just quickly to show you how I like to create my short axis, I always start with the axial, which is the fake 4-chamber. We do it on MRI all the time. Now I have a fake 2-chamber, open the apex on the 4-chamber, and now you start having a short axis from here. You will go ahead and double oblique to open your ventricle, try to find the papillary muscle, the anterolateral one, and then try to intersect it to some degree and cut the RV free margin. So this is a proper 4-chamber. So you go back and forth on the short axis. I'm coming down, and as you pointed out here, it appears to be there's a small cleft here. So, and again here, let me just open it better on the 4-chamber. You see it here, folks. So this is a cleft. What the significance of it, we see it also on MRI. I've done some time screening MRI for individuals with family history of HCM with really sudden cardiac arrest, and they're more aggressive. Even the echo doesn't stop like the screening. So we do MRI. So sometime in the absence of well-defined HCM based on the criteria, but strong family history, I think this could be a kind of a manifestation of early HCM. But in general population with no HCM, no family history, it's just some incidental finding. It doesn't mean much, but this is a cleft, so good job. The next case will be, any other questions? All right.